Okay, so we went over the basic anatomy of the respiratory system. Let's jump into some of the physiology. All right, you already know that inspiration is breathing air in, expiration is making it exit. It's pretty straightforward. The one that has in the name, you're bringing air into the lungs. The one that has X, you are making air exit the lungs. It's logical. All right, so atmospheric pressure is the pressure of the air surrounding the body. And at sea level, obviously, this is going to vary slightly whether there's a storm or not. But it's around 760 millimeters of mercury. I think that's around 15.7 square pounds per square inch, whatever. Um, all respiratory pressures are described as in relationship to the atmospheric pressure. So if you have something that is lower than the atmospheric pressure, then you have a negative respiratory pressure. If you have something that is at a higher pressure than the atmosphere, then it's a positive respiratory pressure. Um, that's a fancy way of saying that if you have positive respiratory pressure, you have higher pressure in your lungs than you do in the air of the atmosphere, and you're going to be exhaling, pushing air out of the body. Anyway, if the respiratory pressure is 0, that means that it's the same as the atmosphere. The pressure in the alveoli is the intraalveolar pressure, and it fluctuates with breathing. Obviously, interalveolar pressure is lower whenever you're breathing air in and higher when you're breathing air out. These are temporary conditions. It's going to equalize with the atmosphere as the lungs finish filling or finish emptying. The pleural cavity, the pleural pressure. See, this is a detail that's not super clear to a lot of people. When your ribs move or your diaphragm moves, the serous layer, the parietal pleura, stuck to them moves. And through surface tension, that pulls on the other layer, the visceral layer that's stuck to the lungs. So say over here to this side, I've got ribs, and attached to the ribs, I have visceral pleura. When the visceral pleura moves out, the parietal pleura will want to follow it. So when the parietal pleura moves out, the visceral will want to follow it. Why? Because of surface tension, because the molecules of serous fluid here are pulling on the one here, 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 and that whole slit-like cavity wants to move out. But when it first starts happening, when the ribs first move out, when the parietal pleura first moves out, you're going to, in this space that I'm increasing right here, you're going to have a tiny drop in pressure, which is why you suck the visceral layer and the side of the lung out. Anyway, so it will always be a negative pressure. The intrapleural pressure will always be a negative pressure. So if you think about this, it needs to be negative because you need to have these sucked together. You need to have the two walls, the two layers of the serous membrane holding on to each other. If it was higher than the atmosphere, you collapse the lung. So anyway, always a negative pressure, usually 4 millimeters less than the pulmonary pressure. You keep the fluid at a minimum. What they're saying there is you have a slit-like cavity. It's not wide. It's not full of a lot of stuff. If any excess fluid does form in there, it's removed by the lymphatic system. If fluid accumulates, the pressure will go up and the lung will collapse. Bad. So two forces tend to promote lung collapse. The lungs have all that elastic fiber and they want to recoil. They want to return to their normal size anyway. Come here, Gertrude. Sorry, dog's yelling. The other one is the surface tension of the alveolar fluid. So the elasticity in the alveolar wall makes the lungs want to shrink. So does the surface tension inside the alveoli. They make the alveoli want to shrink. That's why I had said that releasing surfactant in the alveoli keeps the walls from sticking together as much as they want to. All right, hold. And let me. Okay, folks, I'm back. The dogs are quiet and not fighting, so let's continue. The interpleural pressure is the pressure between the two layers of the pleural membranes. The serous membrane, so it's got serous fluid in between. One layer is stuck to the diaphragm or ribs. That would be the parietal layer. The visceral layer is stuck to the organ, to the lungs. It always has a slightly negative pressure. What that means is it's about if you had a positive pressure, if you had more pressure in that space than you did in the lung, you collapse the lung. So we try to keep the pressure down. We keep the amount of fluid down. Anyway, moving on. So now, two inward forces make it more likely to have lung collapse. The lung has all those elastic fibers on the alveoli that we talked about. And also there's the surface tension of the alveolar fluid. Now remember, the surfactant inside has a lower surface tension than, say, if it was just coated with water. All right, so interpleural pressure says 1 hour force tends to enlarge the lungs. The elasticity of the chest wall pulls the thorax outward. Well, yeah, but you also have muscles to do that. You have your intercostal muscles to do that. Negative interpleural pressure is affected by these opposing forces, but maintained by strong adhesion between parietal and visceral pleural. What they're saying is that the surface tension is strong with the serous fluid. So transpulmonary pressure, trans meaning across, is the pressure that keeps the lungs open, keeps lungs from collapsing. And what that is your pulmonary pressure minus your interpleural pressure. Great. The greater the transpulmonary pressure, the larger the lungs will be. The lungs will collapse if the interpleural pressure is equal to the pulmonary pressure, or if the interpleural pressure is equal to the atmosphere. But you already know that shouldn't happen. We already said that we should be about 4 millimeters of mercury lower than the atmosphere. The interpleural pressure should be lower. Now, if you don't have it lower, the lungs will collapse instead of inflating. And this is a danger that can happen, like improper holding your breath. You should never hold your breath when you scuba dive. But if you did something like that, one danger would be the possibility of getting an air bubble escaping the lung, getting into the interpleural space, and then collapsing the lung as it expands and has no way to vent. Anyway, here we go. So what they've done to make this easier to see, this gray area is the interpleural space, and they've made it big. That's normally, like, see my two fingers, the little tiny space between my fingers. It's like that. It's this little slit-like space. Anyway, so interpleural pressure is right here. It's lower. and atmospheric pressure right there. Interpulmonary pressure, inter meaning inside of, pulmonary, this is the pressure inside the lungs. And they're showing this as being equal because that is where you will end up eventually. Obviously, if you have lower pressure in the lungs, atmospheric pressure will flow in until they equalize and they're the same. If you have higher pressure in the lungs, air will flow out until they are equal. So yeah, that's accurate. The transpulmonary pressure, the difference between what's happening pressure-wise in the lungs and what's happening in the interpleural space, that's what keeps your lungs inflated. Great. So here's how they're talking about pneumothorax. Hadn't even thought of that. Yeah, the scuba diving accident would work, but yeah, a knife wound. So what they're showing is a knife wound that hasn't collapsed the lung, but it has made an opening that air can go in and into this interpleural space. And when that happens, the air goes in and the lung collapses because there's no difference left between them in pressure. And the difference is what keeps your lungs inflated. What I was talking about was instead of a knife wound here, you can actually get a rip in the lungs if you're doing the wrong thing and holding your breath when scuba diving. And that will let air escape here, go into there, then they'll be equal and you'll collapse the lung. This could also happen if you smoke a lot and your lungs lose elasticity. That happens. And when the lung loses elasticity and you try to expand it, you might get little tears, little rips, and that'll let air escape into the interpleural pressure, escape the lung. It'll come from this side, not from the outside, but you'll still end up collapsing the lung. That's why a lot of older smokers in nursing homes can get collapsed lungs. All right. Atelectasis is a lung collapse when you have plugged bronchioles. It can collapse the alveoli. Pneumothorax, which is what we were just looking at, that's air. Pneumo means air, so it's air in the thorax, but specifically it's air in your pleural cavity. This could be a wound in the parietal pleura, the periphery, like the knife wound they just had the drawing of, or a rupture of the visceral pleura, like I said, the scuba accident or the tears when someone smokes. You treat this by using a chest tube to suck the air out of the interpleural space. When the pleura will heal, um, and you have a complete sealed layer, then the lung can reinflate. Until then, you have to figure out how to keep them alive. So what do? You usually hook them up to a machine. Um, and mechanical process depends on volume changes in thoracic cavity. I shouldn't say hook them up to a machine. That's one method that I think can be used. I'm not a medical doctor, so I don't want to go on a limb there. But yeah, so pneumothorax, inspiration, expir. Oh, yeah. So we're not talking ventilation. This is a new section, 1 and 4. So pulmonary ventilation. Ventilation is the movement of air. Consists of inspiration, where we're pulling the air in, and expiration, where the air is exiting. But either one is ventilation, movement of air. So ventilation, movement of air, is a mechanical process. It depends on changes in pressure in the thoracic cavity. Makes perfect sense. When the diaphragm drops, you increase the volume of the lungs, the pressure goes down, and the air flows in. Yeah. When you use your intercostals to expand, to pull your ribs away from your midline, move your ribs laterally, you expand the lungs, make the lungs bigger, reduce the pressure in the lungs, air flows into the lungs. Pressure changes lead to flow of gases to equalize pressure. This is very true, but I want to say it in a manner that's more simple, more easy to follow. Air always goes from high pressure to low pressure if you let it. Air will always move away from the high pressure and towards the low pressure if you let it. All right, so Boyle's law, this is the PV equals nRT. That's the relationship between pressure of a gas and the volume of the gas. If the amount of gas is the same and the container size is reduced, the pressure goes up. That's what happens if we let the diaphragm rise. The diaphragm comes back up, or the ribs come back in. Then we had a certain amount of air in the lungs become smaller, so the container size is reduced, and the pressure in the lungs goes up. What happens as a result? Air is moved out, exhalation occurs. So, all right, so inspiration, we have inspiratory muscles, the diaphragm and the external intercostals. And I want to make sure that you understand here, the diaphragm is the only muscle involved in breathing at rest. The intercostals are not used unless we are doing active breathing, things that require us to breathe deeper, breathe harder, then we're going to use the intercostals. But when we're at rest, and we call that breathing at rest tidal breathing, because it's just like the tide, it goes in, it goes out, there's no drama. When we are doing tidal breathing, it's just the diaphragm. Or it says a dome-shaped diaphragm. There's probably a picture coming up. Yeah, there's a picture, but it sucks. Let's go back to this picture. All right, you see the diaphragm in this picture, and you see how it sticks up there? That's the dome-shaped thing that they're talking about. So look at this. The muscle is like that. And remember, muscles, whenever they contract, they get shorter. So the diaphragm is a muscle, and it's shaped like this. Well, let me move there we go. So the diaphragm is arched. When the diaphragm contracts, gets shorter. That means that curve straightens out as the muscle tightens, as the muscle contracts. Then when the muscle relaxes, that's not because the muscle's causing movement, that's because the lungs are now trying to go back to their original size, and they're pulling on the pleura, and the pleura are pulling on the relaxing muscle, and the relaxing muscle goes back to its arch. But when the muscle contracts, it gets shorter. What I mean by shorter is not this. What I mean is shorter. So I'm going to do it here. We'll move this way far away so it's easier to see. So this, see how my fingertips are barely touching? You would agree that fingertips barely touching, the space between my thumbs is I would call this long. Now, if I do this, the space between my thumbs is short. Okay, long, short. I'm going to make the same motion, but with a curve in here. We have long, we have short, we have long, we have short. That's what the diaphragm is doing. When the diaphragm contracts, my thumbs move together. When the diaphragm contracts, the distance is shorter. When the diaphragm relaxes, the distance is longer. All right. Enough of that. So the diaphragm is dome-shaped, and when it contracts, it moves inferiorly, meaning downward, and it flattens out, gets rid of the dome. This means there's an increase in thoracic volume. There's going to be ultimately an increase in the volume of the lungs. And so the pressure is going to go down and the atmospheric air will rush in. Inhalation will happen. The intercostal muscles, when they contract, the sides of the rib cage are lifted away from the midline of the body. The sides of the rib cage move laterally and upward. And says when a handle of a bucket is raised outwards and it moves upwards. But the point is easy to see. Look at the space between my hands. Here, I'll move it back. Look at the space between my hands. If we go like this, there's more space between my hands. So when the muscles, the external intercostals contract and pull the ribs externally, there's more space in the thorax, there's more space in the lungs. That means there's lower pressure in the lungs. That means air rushes in to fill the space. Okay, yeah, so inspiratory muscles contract, the diaphragm goes down, the rib cage rises. So diaphragm goes down, rib cage rises. Both of those are going to cause the thoracic cavity volume to go up. The lungs will get stretched. The intrapulmonary volume will increase. As the volume goes up, the pressure drops. As the pressure drops, atmospheric gases flow in. Inspiration. We're pulling air into the lungs. Then the opposite can happen. When the diaphragm relaxes, when the ribs relax, the intercostals moving the ribs relax, everything returns to its narrower, its smaller volume. Smaller volume, higher pressure, air exhaled. All right, so we got that. So inspiration, as the thoracic cavity volume increases, the lungs get stretched and they're pulled out. That causes a drop in intrapulmonary pressure. And because there's a difference, air always flows down its gradient. Fancy was saying air always goes from higher pressure to low. If we had a drop in intrapulmonary, atmospheric is higher, air will move into the lungs. Okay. I wish I had the model that's at school. We have a fabulous little model that you can see that when you pull on the diaphragm, the intrapulmonary pressure goes down, which means the interpleural pressure goes down, which means the air flows in. It's a great model. Anyway, inspiration, forced or deep inspiration. That's what happens with exercise or people with COPD. Accessory muscles are activated. We're using the scalenes, the sternocleidomastoid, the pec minor. You can straighten the back of the thoracic curve. These things will increase the thoracic cavity and make a bigger gradient so you can pull air in. All right. So forced inspiration, exhalation. There you can see we're doing the exact same thing. And since there's a 1 right over here, that means they're going to bounce through, but it's the same thing. All right, expiration is the opposite. Well, I shouldn't say the opposite. Expiration is the bottom half of this picture. All right. So in expiration, quiet experience is passive. That's a way of saying quiet expiration does not require you to spend energy. You're not spending muscle to force the air out. What happens is the diaphragm relaxes and returns to its arch shape. The ribs, if they were pulled out, you relax the intercostals and the ribs come back. Both of those things are passive. Why would the diaphragm come up? It's because those stretchy lungs try to return to their normal shape, and as they pull everything back. Sorry, as they contract, as they get smaller, they pull everything back. They pull the diaphragm up, they pull the ribs in. Okay. This will causes intrapleural pressure to increase. The volume going down, sorry, the volume going down is going to make the pressure go up. So then you have the pulmonary pressure higher than the atmospheric pressure. So the air will flow out. Again, it's down the gradient. The air always moves from an area of higher pressure to an area of lower pressure if we let it. Forced expiration is an active process that uses the oblique muscles, the transverse abdominal muscles, and the internal intercostal muscles. So yeah, breathing, exhaling is normally passive, but if we do forced, if we're doing active, we're using energy, we recruit and use a bunch of other muscles that are not normally part of the breathing process. But that allows us to move air more quickly, move air further. I should say further, move air more quickly, contract more. All right, so here we go. Um, what's happening to the three pressures? Atmospheric pressure, we're assuming, is the same. If the interpulmonary pressure goes up, high pressure here, high pressure in the lungs, nice and pink. You have lower pressure on the outside of the air in the atmosphere, and you're going to have the volume of the breath go down. Why? That's exhaling. Oh, it says at the top. We should have gotten that. Inspiration, inhaling, drawing air in, that happens when the pressure in the lungs is low and the lower than the atmospheric pressure, and air flows from high to low, and the lungs fill with air. It's pretty straightforward. Now, there are also non-respiratory movements of air. You can move air in and out for other reasons. You could do it to modify the rhythm, but coughing, sneezing, laughing, crying, yawning, hiccuping, all of those are moving air as well. So, what factors affect the ventilation, the movement of air? Resistance, alveolar surface tension, and lung compliance. How much the lungs want to stretch or not stretch. And airway resistance, you'll remember, that's, hey, that smooth muscle in the bronchioles. What are we doing? Are we bronchioconstricting or bronchiodilating? So airway resistance has two things. There's friction, which is non-elastic. You can't change that much. It's there. So friction exists, but the cross-sectional area can be changed, which means you can change the resistance. So flow is change in pressure over resistance. The change in pressure is the difference between the atmosphere and the alveoli. It's real low in quiet breathing, tidal breathing. Well, I want you to know the term tidal breathing. The 2 millimeters of mercury difference is enough to move half a liter of air. Gas flow changes inversely with resistance. So if you have more resistance, you have less gas exchange. So resistance in the respiratory tree is often insignificant. Two reasons. One, the diameters in the first part of the conducting zone are huge, and the branching of the airways as they get smaller leads to an increase. So you have even more cross-sectional area, even less matters. Any resistance that happens is a medium-sized bronchi. This disappears at the terminal bronchioles. You have almost no resistance again, where diffusion is what drives gas exchange. So basically, long ramble, what they're getting at is the medium-sized bronchi are the ones that do most of the resistance. Okay. So medium-sized bronchi, most of the resistance. We've got that. If air resistance rises, breathing takes more effort. Severe constriction or obstruction of bronchioles can prevent you from ventilating well, which can kill you or make you really sick. This could happen when you have acute asthma attacks that could stop you from breathing. If this is the case, we'd probably give people epinephrine to cause the bronchioles to dilate and reduce the resistance. So it's easier to move air. So we've done that. There were three factors here. Airway resistance, we've done with airway resistance. Now we're talking alveolar surface tension Then we'll do lung compliance. So the surface tension, the attraction of liquid molecules to one another. Well, molecules trying to hold on to each other. This draws liquid molecules together, reduces contact with dissimilar gas molecules, and resists any force that increases surface area of the liquid. Yeah, fine. Water has a high surface tension, and it coats the alveolar walls in a thin film. It tends to take that little round alveoli and make it want to collapse. So we have to release surfactants into it to make it less surface tensiony. So surfactant is a body's detergent like lipid. I hate the way they're wording this because soap is a surfactant. Surfactant is something that reduces surface tension. What they should have said is the body's detergent like lipid serves as a surfactant. Anyway, your body's surfactant is a detergent like mix of lipids and proteins that will reduce the surface tension in the alveoli. This will keep the alveoli from collapsing, and this surfactant is made by the type 2 cells. You need to know that. Surfactant made by the type 2 alveolar cells. If you don't have enough surfactant, you have lung problems. Premature babies, the ones they keep in incubators because they have trouble breathing, they're born having infant respiratory distress syndrome because their type 2 cells that make their surfactant aren't fully developed yet. Or they don't have enough of them. Anyway, they're not making enough surfactant. So increased surface tension results in the collapse of alveoli after every breath. They have to be reinflated in every inspiration. That takes a lot of energy. This is common in premature babies. Fetal lungs do produce adequate amounts of surfactant until, it should say do not. Yeah, this is a typo. Fetal lungs do not produce adequate amounts of surfactant until the last 2 months of development. Great. Treatment. You could spray natural or synthetic surfactant into the baby's air passages. You might have to hook them up to a ventilator to breathe for them. Mechanical ventilators are good, but they have side effects. Survivors of the mechanical ventilation may develop bronchial pulmonary dysplasia, chronic childhood lung condition. All right, so the third of the three things, again reminding you, the three things that affect the how easy it is to move air, affect the resistance, are airway resistance, the surface tension, which you just did, and now we're going to do lung compliance, how stretchy a lung is. This is where the smoking comes in that we were talking about. All right, so lung compliance is a measure of how well the lung changes volume with a given change in pressure, transpulmonary pressure. It's measuring how stretchy the lungs are. Normally, the lung is really high in stretchiness. Like you have a lot of elastic fibers, you have a lot of surfactant. The lung is that means because it stretches easily, it's very distensible, means it gets bigger easily. The surfactant will decrease the surface tension inside the alveoli. The higher lung compliance means it's easy to breathe. It's easy to expand and contract the lungs. All right, so here is math. Oh my God, but it's not bad math if you think about it. Lung compliance, that's CL, compliance of the lung, is change in lung volume divided by change in change in the difference in pressure between the pulmonary pressure and the interpleural pressure. So transpulmonary pressure, I believe, was the term. Let's double check before I say it wrong. Yeah, it's transpulmonary pressure, but that's not the diagram I want to show you. This one. So the bottom of that math formula is the difference between this pressure and this pressure. And we call that difference the transpulmonary pressure. Yeah. All right, so a change in the transpulmonary pressure. Lung compliance is change in volume of lung divided by change in transpulmonary pressure. All right, compliance can be diminished by non-elastic scar tissue replacing the lung tissue. We call this fibrosis. Reduced production of surfactant. That happens with like pleurisy, inflammation of the pleura, or decreased flexibility of the rib cage. So anything that decreases the resilience of the lungs diminishes lung compliance. You can have chronic inflammation, infections like tuberculosis. They can cause scar tissue to replace normal lung tissue. Scar tissue is not as stretchy, so the lungs lose compliance. You could not make enough surfactant. If you stop making surfactant, start making enough surfactant, the lungs are reduced in compliance. The lower the compliance, the more energy you have to spend just to breathe. Total compliance to the respiratory system also influenced by compliance or how easily the thoracic wall distends. This can be affected by ossification of costal cartilage. If as you get older, the cartilage starts to pick up a lot of calcium, then it doesn't flex as easily. You could also have deformities of the thorax. You could also have paralysis of the intercostal muscles, like from damage from an accident or something. All right. So respiratory volumes can be used to assess respiratory status. Um, we can combine volumes to calculate respiratory capacities and give information on a person's respiratory status. Volumes and capacities are usually abnormal in people with pulmonary disorders. Spirometer, that's where you breathe into the thing. It tells you how much air you can move. They were the original electronic tools used to measure patients' respiratory volumes. Now we tend to use electronic means. All right, finally, the term I've been using, men say, oh, you really need to, and I've been saying you really need to know that term. Tidal volume is the amount of air moved in and out with each breath at rest. They're not saying that, but it is. Tidal volume is how much air you're moving in and out, and it's about a half liter. The inspiratory reserve is the extra amount you could breathe in. Like I'm breathing in, I'm breathing out, I'm breathing in, I'm breathing out. It's about a half liter, and all of a sudden I breathe in more than normal. That's your inspiratory reserve, the amount of air that you could breathe in beyond the normal tidal volume. And that's somewhere between a little over 2 liters and a little over 3 liters. Now, you probably guessed, you normally breathe air in, normally breathe air, breathe in, breathe out. That's your tidal volume. But it's possible that you could breathe out more than normal. That would be your expiratory reserve. There you could forcibly expel. Now, there's some air usually down the bottom of the lungs that doesn't move out at all. It's stuck there. That is your residual volume, the amount of air that's always in there. You need that to keep the sides of the alveoli from sticking to each other. So you could do combinations of these volumes to make other things. The inspiratory capacity, meaning the amount you can inspire, the amount you can breathe in, that is your tidal volume, what you normally breathe in and out, and the inspiratory reserve. So easy to explain. If you were to breathe out all the way, all the air you could, and then you just relax, you're breathing in, actually, no, that's not true, you're breathing out more than normal. But tidal volume, again, the amount you normally breathe in and out, about a half liter. Inspiratory reserve, that's the extra you could breathe in. The combination of the two is inspiratory capacity, the total amount of air that you could breathe in. Now, your functional residual capacity, that's your residual volume, which you can't control. That's the amount of air stuck in your lungs, and the expiratory reserve, the extra you could breathe out if you had to. The vital capacity, vital capacity is the tidal volume plus the inspiratory reserve plus the expiratory reserve, meaning the maximum amount that you could breathe in and then breathe out. Or another way to say that, everything except the residual volume, because you can't use that. Your total lung capacity is all the volumes together. Just add it up. All right, so we look right here. Spirograph for a male. Tidal breathing, tidal breathing, tidal breathing. But in between here, we have a big inhale. That's inspiratory reserve being filled. And then we do our normal tidal breathe out, but we continue. We breathe out a lot more air we normally don't. This is expiratory reserve. So you will probably, I've done this in the past on other tests. We'll see if I do it this time, but I've given people charts like this and had them label what is inspiratory reserve, what is expiratory reserve, using the abbreviations. What is the residual volume, etc. Hold on a second. Okay, folks, sorry about that phone call. Moving on. You might see a chart like this on the test and have to fill it out. Or you might have math problems where you need to show that you know how to use the formulas and that you know the formulas. So be aware of that. Okay, and here are descriptions of the typical volumes. I'll be honest, if I do give you math problems, I probably won't use these volumes. I'll use similar ones, but with round numbers, so they are easier to do without calculators, because I don't want you needing to use a calculator. All right. But yeah, pay attention to this. This is useful information. So you know that the air you can't move in and out of the lungs is called residual volume. Well, the air that you can't do gas exchange, we're talking about conducting zone, but all the air in the passages, that's anatomical dead space. Alveolar dead space is anatomical dead space is any space where you're not doing gas exchange. And this is the air in the passageways that you're not using. So 150 milliliters out of the 500 milliliters you breathe in and out for tidal volume. The alveolar dead space is collapsed or damaged alveoli. Any air that is in there, you can't do a gas exchange with. So total dead space is anatomical dead space plus alveolar dead space. That's not surprising. All right. So we can use spirometry to tell the difference in obstructive pulmonary disease, like bronchitis, and restrictive pulmonary disease, like tuberculosis or fibrosis. So if you have bronchitis, your total lung capacity, your functional residual capacity, your reserve volume may be higher than normal because you've got hyperinflation of the lungs. Lungs are more inflated than normal. If you have a reduced total lung capacity, like tuberculosis, or exposure to environmental agents that cause fibrosis, then you're going to have reduced vital capacity, reduced total lung capacity, reduced functional residual capacity, and reduced reserve volume because your lung expansion is not working well. Okay, so pulmonary tests can measure the amount of gas that we can move and how fast we can move it. An example of that would be your forced vital capacity. Look at your forced vital capacity. That's the amount of air that you can forcibly expel after taking a deep breath. Okay. And forced expiratory capacity is gas expelled during a specific time interval of the functional vital capacity. So, amount of air you can expel in a second. Healthy individuals can expel 80% of their vital capacity, functional vital capacity, in 1 second. If you have an obstructive disease, you can exhale less than 80% in that first second. Those with a restrictive disease can exhale more than 80%, even with a reduced lung volume, reduced functional vital capacity. We also can measure minute ventilation, the total amount of gas that flows in or out of the respiratory tract in a minute. Normal measurements for at rest might be around 6 liters a minute. Normal when you're exercising might be 200 liters a minute. And this is still only will only give you a rough estimate of respiratory efficiency. Alveolar ventilation rate, AVR, is a measure of the flow of gases in and out of the alveoli during a particular time. This is a better indicator of how effective your ventilation is. And this will take into account the amount of dead space you have, your tidal volume, your rate of breathing. So alveolar ventilation rate, there's your formula. It's not a bad formula. It's a much cleaner formula than some of the others. I will probably use a question or two off of that. Because dead space in an individual is usually constant, AVR is affected by tidal volume and by frequency. Significant increases are brought on by increasing tidal volume rather than changing frequency. Rapid, shallow breathing can actually decrease the alveolar ventilation rate. What that means is that rapid, shallow breathing actually doesn't get that much gas exchange, doesn't get that much air into the lungs. You might say, why? Well, because if it's too shallow, what you're doing is moving air in and out of the conducting zone, in and out of the dead space, the trachea, the bronchi, where you can't do gas exchange, and that won't do you any good. All right. Effects of breathing rate and depth on alveolar ventilation. You can see what we just said. Rapid, shallow breathing. It's going to change your effective ventilation rate by only 40%, where slow, deep breathing is going to change it by 85%. So if you're having trouble getting oxygen, slow, deep breaths. Gas exchange. So ventilation is all about moving air. That's what we were just talking about. Now we're going to talk about gas exchange. That means the external respiration, that's what's happening in the lungs, and the internal respiration, what's happening in the tissues. Both processes are dependent on the properties of the gases, the partial pressures of the gases, and the composition of the alveolar gas, what actually is in the alveoli. So the total pressure by a mix of gases is equal to the sum of pressures exerted by each gas. Yeah, that's not surprising, you would think, but the practical upshot is very interesting, at least for scuba diving. So partial pressure is the pressure by each gas that is part of that mix. And it's directly proportional to the amount of it in the mix. So total atmospheric pressure, 760 millimeters of mercury. Nitrogen's 78, 79% of air. So the, well, they're saying we'll be specific, 78.6. So there you have the partial pressure of nitrogen being 590, because that's 78.6% of the 620, which is their atmospheric pressure. Oxygen is 20.9%. So the partial pressure is 20.9% times 760 gives you 159 millimeters of mercury. So the book is not going to go deep into scuba diving and stuff, but just for your information, the deep scuba divers, not the kind of stuff I do, but the people who dive really deep, like commercial divers and stuff, breathing mixed gas instead of air, they could be breathing stuff that's a much lower percentage of oxygen. That the gas they breathe could have very low percentages of oxygen, like 5%. But the goal of all this mixed gas is to keep the same partial pressure as if they were at the atmosphere. So if they're breathing at really low percentages, but they are at a high total pressure, it's going to work out to be about the same. Anyway, so air is about 0.4% of carbon dioxide and 0.5% of water vapor. And at high altitudes, the partial pressure goes down, but at low altitudes underwater, partial pressure increases significantly. That's an understatement. You go up 1 atmosphere, 760 millimeters of mercury, for every 33 feet of fresh water or 27 feet of salt water. So the deeper you go, the more issues you have with like loading the body with nitrogen that you have to get rid of. So comparison of gas partial pressures and approximate percentages of that in the atmosphere and the alveoli. So here we're seeing that in the alveoli, you have, back up, in the alveoli, notice that your levels of CO2 are greatly elevated. Normally in the atmosphere, you have 0.04% of carbon dioxide, and you have 5.2. Why? Why is because we are loading up the lungs with carbon dioxide that we're going to breathe out. This is how we get rid of carbon dioxide. Oxygen in the air, normal air, it's going to be 20.9%. It's down to 13.7. Why? Because we are pulling oxygen out of that air to chuck into the blood. Okay. So Henry's law, for every gas mixture that's touching a liquid, each gas dissolves in proportion to its partial pressure. Yeah, what that means is that since the bulk of air is nitrogen, nitrogen dissolves pretty well into the liquid, into your blood. And at equilibrium, they'll be about the same. But every substance, every gas has a solubility. And what this means is like, take carbon dioxide. Carbon dioxide is a lot less common in air, a lower partial pressure than oxygen. But carbon dioxide is way better at dissolving in water, in liquid. So, which direction are we going? There we are. Yeah, that's what I was looking for. Okay. So carbon dioxide is more soluble in water than oxygen, and little nitrogen will dissolve. As the temperature of a liquid rises, solubility decreases. This means that cold water is better at holding oxygen than warm water. So, yeah. So homeostatic imbalance. If you're breathing oxygen gas at 2 atmospheres, it says it's not a problem for short periods of time. However, oxygen toxicity can develop rapidly when the partial pressure of oxygen is greater than 2 to 3 atmospheres. That's why they would dilute the air. When I said those deep divers, why are you breathing something that's such a low percentage oxygen? It's because they're trying to make the partial pressure of oxygen stay out of that range. If you have too much oxygen, you have lots of free radicals running around attacking the central nervous system. This could cause a coma. This could even cause death. We call this oxygen toxicity. If you're staying on land and you're not in a hyperbaric chamber, you don't have to worry about this stuff. But if you spend time underwater, it matters. So the alveoli have more carbon dioxide and more water vapor than the atmospheric air because we are doing gas exchange. We're trying to load the lungs up with carbon dioxide. It also has more water vapor because we, remember, warm and moisten the air as we inhale it. All that moistening of the air is loading it up with water vapor. We mix the alveolar gas with every breath. New air mixes with the air that was left in the passageways, in the dead space. Okay. So external respiration, I already told you, is exchange of gas across the alveolar wall to the blood. We're trying to load the blood with oxygen and take carbon dioxide away. And what affects how we can do this? Partial pressure gradients and gas solubilities. That's one thing. The thickness and the surface of the respiratory membrane. You remember, we're using squamous, squashed thin cells to make up the alveolar wall, because the thinner it is, the better it is for gas exchange. And ventilation perfusion coupling, how well we match where the air goes to where the blood goes. Anyway, let's move on. So partial pressure gradients and gas solubilities. There's a big gradient for oxygen between blood and the lungs. Venous blood has 40 millimeters of oxygen in it. Why? Because we're using up all the oxygen in the tissues. So it comes in with pretty low oxygen, 40 millimeters of mercury. The air has 104 millimeters of mercury. That's why oxygen wants to leave the air and go into the blood, because there's a, just like when we talked about ventilation, you move from high pressure to low. Well, you do the same thing when we talk about respiration, move from high pressure to low. So equilibrium is reached across the respiratory membrane in 0.25 seconds, but it takes the red blood cells 0.75 seconds to travel from the start to the end of the capillary. That's just a way of doing backup. It ensures that we get enough oxygen, even if the blood flow is increased. The partial pressure for carbon dioxide is less steep. We do have higher pressure of carbon dioxide in the veins than we do in the air. And so we do move the carbon dioxide. Now you might say, but we're not moving nearly as much because look at the pressure difference. Not true, because remember the solubility? Carbon dioxide is way more soluble. It dissolves better, so we can move it across that barrier more easily. So the practical upshot is we have a different amount of gradient. There's a huge, big partial pressure gradient in oxygen. There's a dinky little one in carbon dioxide. But because they have vastly different solubilities, the amount we move tends to be equal for the two gases. All right. So here is a table summarizing. I wish they drew this in for nitrogen too. That would be great for scuba diving. Anyway, oxygen in the blood, oxygenation of the blood in the pulmonary capillaries at rest. When the capillaries arrive in the lungs, they're very low oxygen. And within a quarter second, we've got them pretty well topped off with oxygen, which is fabulous. All right. So the thickness of the membrane matters. The thicker you make it, the harder it is to transfer gas. That's why we have very thin membranes. We're talking half a micron to 1 micron in thickness. The total surface area of the alveoli is 40 times the surface area of your skin. So many, 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 many alveoli means you have many alveolar walls, which means you have lots of surface area to do gas exchange across. It says the thickness of the respiratory membrane increases dramatically, and that means it gets less good at transferring oxygen. If the lungs get waterlogged, or if you get edema, this is seen if you have pneumonia or failure in the left side of your heart. The 3/4 of a second the red blood cells spin passing through the pulmonary capillaries may not be enough for gas exchange if you have thickened alveolar walls, thickened membranes. The result is that the body will then suffer from lack of oxygen. Pulmonary diseases can reduce alveolar surface area. In emphysema, the walls of adjacent alveoli break down, making it like you have two alveoli here, and sure, they have a little channel, a little pore connecting them. Well, you may break that down until you have one bigger alveoli. You might say, well, what's that matter? Well, there's reduced surface area now to do gas exchange across. Tumors, mucus, inflammatory materials, those can block gas flow into the alveoli. So normal lung, very spongy, lung with emphysema. This is a person who's obviously very sick and having trouble breathing. Their alveoli are much bigger and messed up. All right, so now let's talk about ventilation perfusion coupling. You want to send the blood and the air to the alveoli that are working best. So perfusion is the amount of blood reaching the alveoli. Ventilation is the amount of gas reaching the alveoli. we've got to match those up for optimal gas exchange. So both are controlled by autoregulatory mechanisms. The pressure of oxygen, partial pressure of oxygen, will control arteriolar diameter, how much vasoconstriction, vasodilation we're doing. The partial pressure of carbon dioxide will control ventilation by changing the diameter of the bronchi, doing bronchio expansion, bronchio contraction. So changes in partial pressure in oxygen and alveoli cause changes in the diameter of the arterioles. If the alveolar if the alveolar oxygen is high, the arterioles dilate. What we're saying is, if we've got lots of oxygen in this alveoli to give, we're going to make the blood vessels going there open up, vasodilate, so more blood comes, more blood is delivered. Where alveolar oxygen is low, the arterioles constrict. What we're saying is, if you got a damaged area of the lung, or you just have crap air, you don't send blood to that alveoli. You try to find one that works better, one that has more oxygen in it. This directs the blood to go to the alveoli where oxygen is high, so the blood's good at picking up oxygen. This is the opposite mechanism that we see in systemic arterioles that dilate when oxygen is low, because that makes it easier to deliver oxygen to the tissues, or constrict when high because it's easier to, again, to do the delivery to just where it's needed. Influence of carbon dioxide and perfusion. Changes in carbon dioxide in the alveoli change diameters of bronchioles. If the carbon dioxide level in an alveoli is high, we open the passage that lets us breathe out that carbon dioxide laden air. If the alveolar carbon dioxide is low, we constrict because it's not as important to get rid of that air. This lets us breathe the carbon dioxide out more quickly. Balancing ventilation and perfusion. Changes in the diameter of local arterioles and bronchioles is used to synchronize ventilation and perfusion. It's never perfectly balanced for all alveoli, because you could have differences in different regions, the effect of gravity pulling on blood or air. Occasionally, the alveolar ducts get plugged with mucus in unventilated places, and that messes with things. But yeah, our goal is to deliver blood to where oxygen is prevalent, and open up passages to let us breathe out carbon dioxide as quickly as possible. All right. Internal respiration is the other end of the blood, when we're at the tissues and the tissues are needing oxygen. So internal respiration is gas exchange with the body tissues. Partial pressures and diffusion gradients are reversed, but it's still true. We go from higher pressure to low. So tissue partial pressure of oxygen is always lower than arterial blood. Yeah, that makes sense. Any oxygen is there, you're using it up. You're doing respiration. So oxygen is always going to move from the blood to the tissues, because the tissues are low in oxygen and asking for it. The tissue partial pressure of carbon dioxide is always higher than arterial blood. That makes sense. The tissues are where we are making the carbon dioxide, so it's going to be strongest, most common around the source, the cells in the tissue. And again, carbon dioxide, just like any other gas, is going to move from high concentration to low. It's going to move from around the tissues where the carbon dioxide is made to the blood, so it can be carried away. And venous blood returning from the heart has 40 millimeters of mercury oxygen, very low, and 45 millimeters of carbon dioxide. A bit on the high side. All right, so this shows us the pressure gradients for gas movement in external respiration and internal respiration and how they differ. Yay, Peachy, moving on. Oh, and that is the very end of this chapter. Okay, let's stop the share and